morning. So we're so excited for today to really have these very important conversations around our most vulnerable populations. Those of us who work with the homeless and the unsheltered, we confront one of the most persistent and intersectional issues affecting our city today. And as service providers, I believe that it's a necessary part of our responsibility to come together to share our experiences, to develop best practices. I also believe that any hope of solving this crisis of homelessness in our city relies upon our ability to form effective alliances with each other, all of us here in this room, forming a broad and intersectional coalition to confront it. For years, we've been building those alliances, and we continue to do that today. So I thank you for being here. One of those alliances that I like to focus on, for very obvious reasons, is our important partnership with Care for the Homeless. BronxWorks started in the field of homeless services in the early 1990s when we opened up our Nelson Avenue family residence in the Bronx. We confronted it as a rising crisis across the borough, and practically since the opening of our shelter, Care for the Homeless was right alongside us. They've been there working to engage one of our city's most vulnerable populations, and this partnership synergized since the beginning, where BronxWorks could really focus on the street outreach, on finding permanent housing, supportive housing, and also, of course, sheltering. And Care for the Homeless could focus their efforts on the critical medical and psychiatric intervention, both on the street and inside our shelters. Through these partnerships that create comprehensive interventions that really work to stabilize a homeless person's situation, get them the help they need, get them talking to us long-term, and help us to find them a permanent place to live. As a long-time homeless services provider, BronxWorks has innovated a number of practices in our treatment strategies for our most difficult and challenging cases. We were early implementers of the mobile crisis teams, allowing us to quickly respond to clients needing emergency medical or psychiatric attention. We've advocated for sharing of critical information like the homeless death report or the frail and vulnerable list. And every year since it started, we supported our annual Hope Count with our staff and volunteers. That's a huge lift to do. Over the decades of working with Care for the Homeless, we've seen how homelessness evolves with emergent challenges and how service providers must, in response, adapt their strategies. In the face of the opioid epidemic, we have employed and advocated for the increased utilization of medication-assisted treatment. We immediately got behind promoting access to Narcan for everyone in our shelters, staff, clients, and also people in our communities. We have seen naloxone literally save lives in our programs. Today, we have proven strategies and interventions covering all of our shelter facilities and our street outreach efforts. Over the long term, we have seen chronic street homelessness decline in the Bronx. We continue to grow our understanding of the conditions that lead to homelessness for a person, for a household. And I'm so thankful for Care for the Homeless for being a true partner in this difficult work, for sharing our commitment to meeting our clients where they are in their lives, for treating them with compassion and dignity that they all deserve, that we all deserve. I would like to especially thank Dr. Andrea Littleton, who has been an incomparable companion of this work, going on the street and treating individuals right where they are from the very, very beginning of the partnership that we started with her, and she's just phenomenal. I can't speak more highly of Dr. Littleton. I would also like to thank the leadership of Care for the Homeless, George Nashak, for aligning our missions to serve the most vulnerable residents of the Bronx. Thank you to Care for the Homeless medical and psychiatric teams who work hand in hand with our shelter and outreach staff. And I also want to point out and thank our staff and anyone who really works on the street with the individuals. We at BronxWorks have conversations with the executive director, and very often One of the examples that I have of how to treat someone with dignity and respect is really to look at the staff population that works with those on the street, because they treat everyone with such compassion and respect as they engage them on the street and bring them into the vehicles, bring them into our drop-in center. They are just incredible, dedicated members of the BronxWorks team. I also want to thank our panelists and speakers today, and again, thank you all for joining us in our discussion. There's a statement by Curtis Scott King that I believe is worth repeating as often as possible. The greatness of a community is most accurately measured by the compassionate actions of its members. So while our work is far from over, and while it may seem near insurmountable at times, as long as we can make the difference in the life of just one person, it is work worth doing. So thank you. Now I'd just like to invite up our moderator, Jonathan Santos Ramos, Chief Program Officer at Care for the Homeless. The first panel will be the landscape of New York City Street Outreach Services, and if the panelists can also take the stage and have a seat. Thank you.
Good morning, everyone. I'm Jonathan Santos Ramos, pronouns he, him, él, and I'm the Chief Program Officer here at Care for the Homeless. Monday will be 5 months, so bear with me here. I'll be your moderator for this first panel, and I'm honored to be with this amazing panelists for a discussion that is extremely important and setting the stage for our second discussion. With that, I will give a brief introduction to our panelists. Kareem Walker is an outreach and organizing specialist with the Safety Net Project at the Urban Justice Center. Formerly homeless himself, he is dedicating his life to improving the way that New York City interacts with homeless residents. Cassandra White Hemphill. Cassandra became the Deputy Commissioner for the New York City Department of Homeless Services Street Homeless Solution in January of 2020. Her role requires that she collaborates with her team to creatively strategize to engage street homeless clients who historically do not access traditional shelter for a variety of reasons. Prior to this role, Cassandra was the Associate Commissioner for the New York City Department of Homeless Services PATH Family Intake Center. Thank you, Cassandra. Dr. Michael Shen is a primary care doctor at Woodhull Hospital in Brooklyn. He is the clinical director of the Woodhull Safety Net Clinic, a homeless clinic and street van that serves New Yorkers experiencing homelessness. The Safety Net Clinics that's one of 4, also in Bellevue, Manhattan, Lincoln in the Bronx, and Elmhurst in Queens. And last but not least, Scott Atwater is the Assistant Executive Director at BronxWorks. His portfolio includes BronxWorks Street Homeless Services, Family Shelters, HIV/AIDS Services, and foster care prevention programs. Scott created the BronxWorks Homeless Outreach Team. Welcome to our panelists. So I'll start with individual questions first to get the party started, with the understanding that the perception of what is available may be different provider to provider, but definitely different for those who are experiencing homelessness. Cassandra, why don't you kick us off? What is the landscape of street outreach services, and what role does Street Home Solutions play in coordinating the different services?
So for Street Homeless Solutions, we are primarily tasked with really coordinating all of the street outreach activities that are happening throughout New York City. In 2020, that outreach work primarily was comprised of our contracted outreach providers, so BronxWorks, Project Hospitality, MOC, Breaking Ground, and BRC. And so our contracted outreach providers were the ones who were really doing the street outreach work. Once COVID hit, there was a decision that was made to really expand the outreach in order to bring folks in and keep folks safe. And so the city has since then added more than 100 outreach workers that are city employees who also do this outreach work. One of the things that we've also seen really change and give us more bandwidth is that due to the partnership with Governor Hochul and Mayor Adams, the state also added their safety option support teams that are also out doing this outreach work. So we have more than, I would say, increased the level of street outreach fourfold in terms of the folks who are out there connected with individuals in all 5 boroughs, above ground and in the subways.
Thank you. Scott, you have both city and state contracts that fund the robust street outreach services that BronxWorks offers. Can you talk about the full spectrum of those services and what role they play in the larger landscape of street outreach services?
Sure. Thank you again. It's a pleasure being here, and it's also a pleasure. Our collaboration with Care for the Homeless goes back, 30 plus years. So I just want to recognize that as a start. So we have both the OMH, or the Office of Mental Health Safe Option Support Team, and the DHS outreach contracts for the Bronx. And the Safe Option Support Team has actually given us additional staff and additional resources to really focus on some of our most marginalized clients, those with the most serious mental illness. One of the things our SOS staff have been able to do, for example, if somebody has had to go into the hospital, and we've had a number of people since last winter we've had to issue removal orders for when they've gone into the which forces them to go into the hospital. What the SOS resources helped us to do is really build a bridge with them while they're in the hospital, and really work on a permanent plan, so when they're ready to be discharged, they don't end up back out on the street or in a shelter someplace, but they end up in their own apartments. So that's one of the other things. Another key thing that I think is really important to mention here is that, thanks to the Department of Homeless Services, our budget for medical and psychiatric services for our outreach program has increased dramatically over the last few years. I checked it yesterday. It's now around $800,000 a year. So we now have robust medical and psychiatric resources for people who are on the street. And our medical director, who is also she's a clinician for Care for the Homeless. It's again a part of our collaboration. Eileen mentioned her earlier, Dr. Andrea Littleton. She goes out, she's out on the street a couple of days a week. She meets with people who have opiate use disorder. She really targets people. I think everybody knows there's been this surge in the number of people who've died of overdose. And she's really been an essential part of our plan to get those folks off the street and into some sort of better setting so that they can move on. And we've had some success. Some of the folks that we've had with these serious addictions have actually not only transitioned into temporary housing, but it actually moved on into their own apartments at this point.
Thank you, Scott. Dr. Shen, what role does H&H play in the landscape that we've been discussing, and how do you integrate both the medical component of your intervention with the needs of the supportive services for folks that are unsheltered?
Thanks, Jonathan. So NYC Health and Hospitals, as most of us probably know, is the public hospital system of New York City. We're pretty expansive. We take care of the whole city, and we have many different facilities. At baseline, I think we're a low barrier source of primary care as well as specialty services. But recently, we've developed a new program that helps people access care at an even lower barrier level. And this is really key for people who may have been marginalized by the system, for whom the walls of the 4 walls of the system are difficult to, access care. And so that program is called our Safety Net Clinics, and I run one of them at Woodhull Hospital. In total, we have 4 currently. We currently have a 4-borough approach right now in Manhattan, Bronx, Elmhurst, and Queens at each of our main facilities in those boroughs. And with the Safety Net Clinic is also a mobile street van. So we have 4 mobile street vans that are fully staffed by Health and Hospitals staff. I can speak for Woodhull. Our van is located about 20 minutes walking distance from Woodhull in our community in Bed-Stuy. We have some of our team that are here today, and we operate a couple days a week. We walk around with our roving teams, and we offer currently vaccines. We offer harm reduction services, and hopefully like linkage to care if people need it. That includes both primary and specialty care because we have a direct connect into the system, which I think is one of the most powerful aspects of the program. You know, it's a program that's growing, but we're really hopeful that we're going to be able to better meet people where they are.
Amazing. And Karim, we have gotten an overview of some of the services offered to folks that are unsheltered. Can you share your experience interacting with these systems and particularly what you found most useful at a time that you needed it?
John? Okay. I've been homeless several times over the past few years, though I'm now in my own personal space, thank goodness. But one of the times that I can talk about is an encounter I had with a street outreach team at the at Coney Island, Stillwell Avenue, last stop on the D, F, N, and Q lines in Brooklyn. They were very they were very kind with their time, very polite, but they really did not have much to offer me. And I think beyond a bed and a shelter. And as we all know, unfortunately, the shelter system in New York City leaves a lot to be desired, and it was not something I was prepared to go back into. And it's very clear that there's much that needs to be done in terms of street outreach. And I think it starts with, I mean, there have been times when I've seen outreach teams that don't even offer to bring out, up until fairly recently, didn't even offer water to folks out on the streets. And as we all know, we all need water to live. So it's just, it leaves the system as it currently stands does leave a lot to be desired. And there's a definite room for improvement. That's all I really can say right now, prepared to say.
Thank you for sharing. And through your work, if I could follow up, through your work in organizing, what are you hearing from folks who are unsheltered?
Folks in the almost year and a half that I've worked with UJC, SNP, excuse me, at UJC, a lot of folks are saying some of the same things I'm saying, that not much is being offered beyond maybe, if they're lucky, they might get a stabilization bed, or maybe even a bed in a safe haven, but beyond that, not much is being offered. Some of my clients do get care on the street, which is a good thing, but again, not much beyond that. And I think that's something that really needs to be addressed when we do outreach.
Thank you. There's been a few terms that have, in your sort of first, so I'm going to open this up to anyone who feels they want to explain stabilization bed, safe haven, and we'll start there for folks who may not know.
So in an effort to support folks who are street homeless, the city has a portfolio of beds that are called low barrier beds. And these beds are beds that do not have the same requirements that shelter beds have. And so, for example, if you go into a stabilization or a safe haven bed, you can be out of your bed for 3 days and not be locked out. And that is because we know that when you're working with folks who are street homeless, oftentimes the trauma, the substance use disorder, and a mental illness may make it difficult for them to consistently check into a bed. And so as part of that programming, we do have the flexibility that folks can be outside of their bed for 3 days and not lose their beds. Also, for the safe haven beds, those beds are in clinically rich programs that are supposed to be staffed with psychiatric supports and other supports for the most chronically homeless. The stabilization beds is a model that we recently really expanded. And prior to 2020, the city only had 400 of them. Now we have 1,400 of them. And we've added on, since 2022, 700 additional low-threshold beds. And so we realized right at 2020 that we needed to really expand the portfolio of placements that were available to street homeless individuals, because we realized they are struggling with navigating the regular shelter system, and there needs to be the type of location that allows them to have the flexibility to continuously work through their issues and still have some place to return to. So the city has made a tremendous investment in trying to ensure that we have these low barrier beds. And currently, I think we're up to 3,600, and we anticipate that we'll be at 4,000 by 2024. And that is in an effort to make sure we have a bed whenever possible for folks who want to come in who've been chronically homeless on the street.
Anything to add, Scott, as a provider with a safe haven?
Yeah, we actually operate a number of stabilization beds in several different sites, and we have 3 safe havens as well, which again are these low barrier facilities. I will say, not all safe havens are the same. Some of them are more congregate, where people have to come in and share rooms. They work for certain types of people. And then some of the safe havens are more private. In fact, one of our safe havens that targets chronically street homeless people is only for people who are 50 years of age and older. And the outreach teams really have a good handle. The essence of outreach, to be effective, you really need to know your client and where they best fit. Another thing I just want to mention, I looked at the numbers of the first street estimate, or the hope count that everybody refers to. It was in 2005. It's coming up on almost 20 years now. And the first hope count number, they found 4,395 people in the subways or on the street. This last year, which was high, and again, I think we've really felt the impact of COVID and maybe even more so the impact of the opioid crisis that's really impacting all sorts of neighborhoods, and especially in low-income areas. The number was 4,042. So it's actually, even since 2005, it's an 8%, almost a 10% reduction in street homelessness. In the Bronx, our first hope count number, the estimate was, and again, the hope count numbers are not perfect, but it was 587 people. This last hope count, and again, it wasn't our best year by any means, was 187, and it's been around 100, 150 on and off for the last several years. So that's that's almost a 70% reduction. And how did we get there? One of the things that we did is we focused on people who are chronically homeless. Chronicity matters. We figured out a long time ago that there's a lot of people who are on the street at any given time, especially in the warmer months, that go back to their families, that really, they're temporarily homeless, they make other arrangements. So our focus has always been on the people who've been out there the longest, especially people who spend a whole winter on the street, or somebody who has a very serious mental illness and is hard to engage. And part of what I think has really made this model successful is that the outreach teams have the keys. They know when the client is ready. Sometimes you have to interact with a client 100 times or 150 times before they're willing to go. And the outreach teams have always had the ability to hand the keys to the client to the safe haven bed when they're ready to go. And I think that's really helped. And again, we saw substantial reductions in the best year in terms of the street homeless count was in 2009. There were only 2,228 people on the street at that point. So, it's that number's gone up, and again, but the problems have also increased they become much more complicated.
Thank you. And before I turn it over to Cassandra to add to that, I just wanted to explain that every January, thousands of volunteers across the 5 boroughs participate in New York City's annual homeless outreach population estimate, also known as the Hope Count. So Scott mentioned the Hope Count, just wanted to explain what that was.
And I think it's important to look at this in context. So we've seen homelessness increase across the board in all of the major cities. And we know that that is due to a myriad of issues, including the lack of affordable housing. But I think it's important to look at what New York has done, because the reality is that New York has done more than any other municipality has done. For the homeless people of New York, only 6%, less than 6%, are actually street homeless. Compare that to LA, 70% of the homeless people are street homeless. Compare that to Phoenix in Arizona, 56% of the people are homeless are street homeless. So New York, while it is not perfect, really makes an effort to connect people to services and to give a bed to anyone who wants one, which is something that you do not see anywhere else in the world.
And Dr. Shen, I know that H&H is trying some new things, a couple pilots, some new programs. How are you addressing the robust needs and the complexities that folks have around medical and behavioral health needs?
So I want to connect that also with your previous question about the types of beds. I think, I'm going to speak to everybody here. I'm fairly inexperienced compared to a lot of the people who have been doing this for so long. But I think what that affords me is a pretty fresh view into what I didn't know coming into this. And so part of that was, when I started this work, I didn't know what a safe haven was. I didn't know what a stabilization bed was. There's a lot of confusion, and it's such a complex system that for healthcare workers taking care of unhoused individuals, I think having that big picture landscape understanding is one of the key things, that can help put care into perspective. Speaking to kind of what we do on the behavioral health side, I think that links up a lot with that big picture of the housing journey or the journey of homelessness and that experience. One thing, the things that I didn't know coming in, numerous. I didn't know about the outpatient behavioral health services that the city offers or that various nonprofits offer. I didn't know about ACT teams, IMT teams. I didn't know about SOS teams, which is a fairly recent thing, but I didn't know to tap into all of these resources as a healthcare provider and as a primary care doctor. One of my main roles is supposed to be coordinating care along with our excellent team of community health workers at our clinic. And I can't do that if I don't know about those, that network that's out there. And I will tell you, having graduated from internal medicine residency recently, there's no teaching on the care management aspect of care. There's no teaching on care coordination and what that entails. There's no teaching on who the different members of the team are, what an addiction counselor does, what is a care coordinator, what is a case manager, what is, my residents don't know that every shelter has, people assigned to caseworkers who are specifically supposed to, be helping with their journey. If we don't know that, we can't connect with them, and we can't coordinate care after we see them.
Absolutely. Karim, what are some of the barriers to educating people, do you think, about the services that are available?
I think the biggest barrier is just an overall general lack of available information. If you really don't know what is out there, you really don't know how to solve the problem. And as Dr. Shen was right to mention, I've noticed that a lot of physicians are are largely clueless about and it's not to take away anything about, it's not meant to be pejorative in any fashion, but they are clueless about how folks on the street live, and how folks on the streets try to take care of themselves as best they can when they don't have a roof over their head to make sure that they to sustain their care. So it's very important to us to just educate the population about what is out there, and that's pretty much it.
Yeah, thank you. How do we build the system? excuse me, in a way that information is readily available for all players involved in a client's care? Are there any significant gaps? You mentioned not knowing, right? Why don't you kick us off? What can we do to make sure you
Jonathan,
know?
I feel like you're looking at me.
Yeah.
Whenever for me, one of my first things was I got to teach my residents about this, and our public hospital system is a safety net hospital system, and as such, we have a mission to train the future generation of healthcare workers. I trained at Bellevue at NYU. I was trained in that system, and I learned a lot about caring for a low-income population, our vulnerable populations in the city, where other systems may, kind of fall short. Our public hospital system has done some work on that. And in training people, I think that it comes to, injecting that into the medical education system, but also into the culture of an organization. I think hospitals all have care management programs, but that largely sits at the administrative level. And the people who know about that and understand that are mostly kind of at the top. And I don't know that we've developed a culture where the people on the ground have an understanding of how to utilize their care team partners, how to utilize other players in the field. I think we as a Woodhull team have had really wonderful collaborations with DHS team members, as well as with our local street outreach program, street outreach organization, Breaking Ground. We've learned how to coordinate that, and I've seen many wonderful people, in those organizations who've been really, really willing to kind of work with us on coordinating care. I think that's a culture that's worth developing. And also there's a lot of information sharing at that level. We kind of ask for, hey, can you give us a lecture on this? And I think that's important. Let's develop those educational materials and share them.
Can I say something? In regard to our street homeless population, again, it's not one population. It's a bunch of different populations. A minority of people who are on the street have serious psychiatric problems. And unfortunately, sometimes they don't have capacity, to know that they need to come inside on extremely cold nights, or they'll have really badly infected legs and will refuse medical care. And again, in this afternoon's panel, they're going to talk more about the issuance of removal orders. And, that's one of the things that the outreach providers, in fact, we brought that up, and it took years before DHS actually, or DOHMH actually agreed to license the outreach teams as mobile crisis teams. But that's an idea that actually came from BronxWorks and from outreach providers. But what I would say, again, where I think there's a real need for additional work is with hospitals. And I think everybody who does outreach work in this room can give you story after story about their frustration with hospitals when they have somebody who's extremely vulnerable and the person goes to the emergency room. And there's just a lack of coordination with the hospital. Nobody knows who they can call. Sometimes we've had the experience of our psychiatrist that's embedded in our team. They'll call an attending at the hospital, and somebody who really knows the client very, very well. And the net result is the client still gets discharged, prematurely discharged, or isn't admitted in the first place. So I think one of the areas, and I know DHS is working on this in the mayor's office, Brian Stetton from the mayor's office in particular, but they're one of the areas where we really need to, where the system really needs improvement, is also within the hospital systems, including H&H, for these most vulnerable, patients that we deal with.
Thank you, Scott. Before someone responds, can you just give us a little snippet? I know we're going to go more in the second panel of what a removal order is, but just to be clear.
Yeah, so all the outreach teams in New York are licensed under the Department of Health and Mental Hygiene to issue 958 removal orders. And again, you rarely ever issue a removal order, and it's only in these really extreme situations where you're worried that somebody's going to freeze to death or somebody's illness is so severe that if they don't go to the emergency room that they could die. So in the last year, BronxWorks has, I think, now issued about 16 of those orders. 16 with a population of 1.4 million people is still, it's a very, very small number. But again, I want to emphasize, the issuance of these orders is a rarity. The city is now, has a system in place where they internally track the outcomes of people who've been subject to these orders. And we've actually seen big improvement in outcomes of people who've, been involuntarily transported, to hospitals. So that is one thing in the system, and Cassandra, I know, has been very involved with that as well. It's one of the areas that I think has improved. We had, there's everybody, just another example, there's a top 50 list that it's been mentioned in the newspapers, a bunch of times. It's the top 50, there's two top 50 lists. There's one for the subway system, and there's one for the surface homeless system. I think in the Bronx, our top 50 list a year ago is completely turned over. So everybody on that list now, maybe with the exception of one person, has a roof over their head someplace. And unfortunately or not, a lot of our folks that were on that list, were subject to involuntary transportation to a hospital.
This is back to the education point. I forgot one of my main points, and this is actually to speak to Kareem's point as well. NYC Housing Consortium recently put together a panel with people with lived experience who have diabetes. And I learned a lot from that. I moderated that panel. I learned a lot from them. And I think that that's one of the most important things is like, we often talk about experts in the field from our organizations, but I think, we need to incorporate more peer experts, more people who know actually the experience of the system, because I can say all I want, but I really don't know anything about what that feels like and what it's like to experience. So I learned a lot from that panel, and I think that we should do more of those.
So to Scott's point, he referenced what we call the Coordinated Behavioral Health Task Force. And so this task force is comprised of the top 50 most vulnerable New Yorkers who are street homeless either in the subway or above ground. And this model would absolutely allow us to peel off things that could be used for the broader population. I think what we've learned with this model is that it takes all of the players to be at the table. And so this model is led by managers on my team. It is comprised of all of our partners. So we meet for 4 hours a week, 2 hours for each set. And that's just the meeting itself, but there are a host of meetings and hours of work that go into working with folks on the street. But for the Coordinated Behavioral Health Task Force, there is DOHMH, H&H, all of our contracted outreach providers, our state partners. So we have everyone who may touch these individuals on this call for 2 hours every week. And we spend that time coordinating, talking about what's happening with the individuals and ensuring that everyone knows what everyone else is doing to ensure that we are creating the best outcome for each individual. And what we have found is that the most vulnerable New Yorkers have been able to make strides and change the trajectory. We have people who've been homeless 8 years and never slept inside one day, and now they're in a permanent housing location. And so we have found that just making sure that the city agencies, the state agencies, everyone who will touch these individuals is involved really changes the trajectory. When we were able to get access to psyches, which tells us how long or how often someone goes to a hospital, that's a game changer, right? Because we have access now to know that our most vulnerable person went to the hospital 415 times in a 2-year period, right? So those things are flags, and it allows us to then work with H&H to know what hospital this individual potentially is going to go to, and to work with the IMT or the mobile treatment team to ensure that they are at the hospital and that the SOS teams are at the hospital, and that when this person gets discharged, are they going to go to a long-term bed, which is a bed for psychiatric help, or are they going to go to a safe haven, right? And so having all of the players at the table prepared every week, really digging in and peeling back the layers and ensuring a coordination of services has changed many people's lives. The ability to put this on a large scale is where the challenge is at, but the sharing of information, the sharing of data, and the coordination of services is absolutely necessary if you want to change people's lives.
I would just say, Cassandra, I think we had somebody on that list, the initial list, that had been on the street 20 years. So.
Karim, any idea of how physicians can do better with learning more about folks on the streets?
First, it starts with just listening to the patients, which I think that's the first thing that you learn day one in medical school. Listen to your patients. Because they're giving you insight. They might be giving you insights that you had never considered before, that had never been considered before. That's number one. So if you, I'm going to invoke what my high school, my senior year history teacher said: pretend that I'm absolutely dodo. Pretend that, just break it down for them. If you're a patient, break it down for them. Another thing that physicians can also do is be consistent in the be consistent in follow-up. And number three, definitely learn how to work on gaining their trust, because one thing that being on the street has taught me is that trust is more luxury than necessity. It's something that a lot of us can really afford. So when you come up with when you approach someone on the street, especially someone who's been on the street for 20 years, 10, 20 years, you have to see it from their perspective. They probably had the system fail them multiple times in the past, and here you are showing up, saying that you can help them. It's not going to work like that. So you have to make sure that you're aware of that, and just know that building trust will be a process, because you have to trust them as well.
Any other thoughts on how the expanded directive of involuntary removals has affected your work, or and any of your work, or your work with outreach and education, what you're hearing? Any other thoughts on that?
Yeah, I think we're probably the group that has used the removal order process more than any other group. Again, when we look at people who've been involuntarily transported to the hospital, the outcomes look very good. And 16 people, there were a couple of times where people went to a certain hospital that immediately failed to admit them, and they ended up back out on the street. But in most cases, especially when everybody was notified, and there's this whole email chain that takes place right now, where people have been in the Bronx, they get transported to Jacoby Hospital. There's been a very good response, and and good coordination between our outreach program, our outreach psychiatrist, and the hospital itself. And they've been admitted when they've needed to be admitted. The Office of Mental Health has also a new type of program for extended stay in psychiatric treatment called THUs. And I know Tracy Wilson is here. What's THU stand for? Transition to Home units. I think there's now, about 50 units, if I'm correct, Tracy? 50 beds. People who have gone into those units, their outcomes have been particularly good. In the THUs, there's been a real focus not only on getting them stabilized with medications and so on, but making sure that they don't end up back into the shelter system, so their discharge is to their own apartment. And I don't know offhand how many people have ended up in their own apartment from the THUs that we've worked with. I think we're 4 or 5 at this point. A few people, the apartments are not quite ready, so they're back in a safe haven or some sort of transitional setting, but they're well on their way to having a roof over their head. So I think it's been, I think it's been very positive. And again, in the past, our experience has been, it'll be in the middle of the winter, and somebody will be out in a blizzard. I remember a time we had somebody that was actually barefoot. One of the coldest days of the year, and it's snowing 2 feet. And I remember getting this guy into a hospital. I was floridly psychotic. And, the hospital gave him sneakers and sent him back out into the blizzard. And, to our great chagrin, we thought the guy was going to freeze to death. The fact that that's not happening any longer and for this relatively small group of people, I think speaks to not only the appropriate thing to do, but it's also the humane thing to do in these extreme types of situations.
Thank you. And I believe, Dr. Shen, you called it something else when we talked, right? If you could.
Yeah, so NYC Health and Hospitals have recently expanded an intermediate care level for behavioral health care, and those are called our extended care units, or ECUs. We have 2 currently, one at Bellevue and one at Kings County. They are considered inpatient psychiatric units. They host both voluntary admissions as well as involuntary admissions. And usually the stays are a bit longer than a normal inpatient psychiatric unit would kind of allow, anywhere from 1 to 3 months or more. In the process of treating mental health, there's also work done on housing navigation, and a lot of those individuals end up going to supportive housing. They get their 2010 applications completed, their assessments done, and we are able to discharge them to supportive housing units, or back to where they want to go, depending on kind of the treatment course.
Scott's mentioned a couple of times discharge and folks not getting admitted, being part of being sent back. Any thoughts on that process and what any of you are seeing, or conversations that you're having to try to address folks who providers are sending to the hospital because they shouldn't be at their sites, or they are on the streets and really need to be in a bed but don't get there?
I would say that the city is looking at a host of things. Well, I first and foremost want to say that the work with H&H has been tremendous. I can tell you that from 2020 to 2022, we consistently heard about the struggles of managing street homeless individuals, because we know folks will not go through traditional care. They frequent emergency rooms, right? Or they just refuse services in general. And so the street medicine teams that the city rolled out were really supposed to focus on trying to ensure care and coordinate care. But I can tell you that the work with H&H that has happened over the past year and a half has been tremendous. And we've been able to really change people's lives, and we've been able to collaborate in a way that we have not seen historically. We are on calls probably 3 to 4 times a week with whole medical teams working on solutions for street homeless individuals. And so we know that for this population, they're really afraid of doing things in the way that other people will, going to regular checkups, or when they are admitted to the hospital, they're pushing to be released, even though they may not be in a space where they need to be released. And so there's a lot of work happening around that, but there's still the need to coordinate on a more stronger level. But I can tell you, I've seen tremendous change in the ability to share information, connect with the doctors, connect with the social workers at the hospitals, and be more planful about the outcomes. Currently, when we get a street homeless individual who is being removed to the hospital involuntarily, we can email a series of people at every New York City hospital who will be waiting for this client when they get there. And we are sharing information before the client even walks through the door. And so there's a lot of work happening to connect folks and to ensure that the physician, the attending physician, the CPAP physician, everyone who's going to attend to this person actually knows the background and has a history. And we can advocate on this end because we're looking at psyches and we can say, hey, Bellevue, you have this gentleman coming in, he's been here 200 times in the past year, and we believe some of it was medical, but we also know that he has a history of presenting with serious mental illness. Please, after you treat the medical issue, let's look to treat the serious mental illness. Let's get the psychiatric evaluation. Let's do what we need to do. That way, when he's discharged, he's not going back to the street, but he's potentially going to some place that can connect him to supportive housing. So there is a lot of work happening. There's a lot of coordination happening. And I think that there's still more work to be done, but folks really care, right? We're with people, doctors, outreach workers, clinicians, officers, everyone involved cares, and they're invested in ensuring that there are the best outcomes. The goal really is to expand it, but we're doing it day by day, person by person, with each vulnerable person that presents to us.
I haven't had personal experience with any of the removal orders, but what it comes to me as on the working on the street is it comes as kind of a question about triaging, and in part of that line of questioning, it's both medical but also social. I think what our team tries a lot to do is think about like all of us have set up here, what are some of the past traumas that people have been through, and how do we react in a way that responds not only to kind of the medical and clinical situation, but also to that social and experiential background. One of our social workers on our team, I'm gonna call her out, Nicole Ruiz, who's like really great. She told me something that really resonated with me, which was, as a healthcare worker, I'm very used to having control in the hospital, right? I'm used to being responsible and having control in the hospital, or wanting to control things in the hospital, because that is the healthcare realm. But when you're working out, on the street, you're walking the neighborhood and the community, what she said to me was, you're in somebody else's world. And I feel like that really kind of changed how I thought about the work we were doing, is that you're not really playing by the rules of like what you're used to in the hospital or the clinic. You're in somebody else's world, and you should respect those rules and think about, how you would be in somebody else's home.
We talked a lot about information and getting the information out there, the information available, sharing, coordinating. What about data sharing? And what are some opportunities there for us?
Data sharing is another interesting area that has, in my career, has improved tremendously. So there are now different database systems. There's Street Smart, which keeps track of everybody that's on the street. It's a DHS system. So our outreach program uses Street Smart. There's the CARE system, which is a different database system that DHS also oversees. And that keeps track of people who are in shelter, both families and individuals. In addition to that, and somebody mentioned it, there's the Psyche system, which is administered by the State Office of Mental Health. We've actually had access to the Psyche system, I think, well more than 10 years. I'm not sure about other outreach programs, but it's another really essential tool. It gives you the person's diagnosis. If they have a serious psychiatric problem, it tells you what medications they're on, tells you how many hospitalizations they've had, when their last hospitalization took place. It gives you the name of the ACT or IMT or FACT team, if in fact they are involved in that system. I don't know whether SOS, whether or not they're registered with SOS is yet in the psyche system. It does list the name of the shelter if they're in a shelter program. So it's another really good tool. In addition to that, BronxWorks uses the Bronx Rio. That gives you a different picture of the person's health and mental health. When I talk to our psychiatrist, we have it worked out with the Bronx Rio. So if one of our clients goes to the hospital, we get a real-time alert, and we have to go into the system to see, where the person is, but it will give us a real-time alert. That gives our staff the opportunity to follow up when they're in the hospital. The Rio also gives you a different sort of picture than the psyche system does of where the, what kind of medical challenges the client is facing. So I think there's really been a revolution in the availability of really useful data for clients. The psyche system, ordinarily, you can't go fishing in the psyche system without the client's permission. There are certain exceptions to that. If the client is in an emergency type situation, you can quote unquote break the glass and you can access their records, something that unfortunately we have to do from time to time. You have to ask, you have to get inappropriately so, you have to get the client's permission to access the Bronx Rio system. So there's certain things that are readily available, certain things that are a little bit more, this consent is part of it, which is appropriate. I think all of us would certainly want to be able to ask for our consent before we start handing our medical and psychiatric information over to providers. So there's been tremendous progress in this area.
Karim, what would help with data sharing? What would make it easier? What parts of data sharing across the continuum and through the different providers? How would that impact the folks that you work with and are doing outreach?
Ooh. I don't know if I'm best qualified to answer this question, but I'm going to do my best anyway. I think it would definitely help in cases of an emergency, as Scott was right to mention. There might be a time, we don't know. I'm speaking hypothetically, of course. We may have a medical emergency at like 1 a.m. in the morning, and we need to get access to someone's health records, right, like then and there. So yes, that kind of data sharing could be used for emergency purposes. I have some concerns about that, but that's more from me being a civil libertarian. But
we all have concerns.
Yeah, definitely.
But in a time like you said, if it's an emergency, then yes, we need to go ahead and make sure that because the person's welfare is top priority, should be top priority. And we can only do so much if we don't have all the information available. And I think that's pretty much all I'm going to say.
Thank you. Appreciate that. Anything else on data sharing?
Scott, I wish you were giving a course to some of the residents about all these terms. Rio, Workers Connect, psyches, I-STOP. I think that all of those are important tools that when we're thinking about building programs, we can think about maybe automatically kind of enrolling folks as they onboard. That's what we do in our clinic. I encourage all clinicians who come on board to get their psyches access, psyches is a long process to get, kind of confusing, but I encourage everybody to get all those necessary tools that will allow them to do care coordination. And then also thinking about, like Scott was mentioning, the consenting process. Every person that we engage, we have a checklist of things that we ask, and talk about if we feel like that interaction is heading that way. We get agreement and consent to help coordinate their various teams. We ask everybody, do you know Breaking Ground? Like, can we talk to them? Is it okay if I, look into kind of your mental health record? To help you coordinate care. And we build that into our process. And I think that's a really, really important part of, care. So all of those things, and just learning all the different letters, I think is an important part.
It's alphabet soup, right?
I want to add that I think it's important that when doing this work, there's often concerns about consent and agencies keeping data close to their chest or not wanting to put certain information out. But I've been in a space with my team and all of our partners that we don't allow limitations around data to prevent us from helping someone. We don't need to know the details of what you're doing with someone. We just need to know that you're working with them, right? Because if we know the services that you can provide, we can then also try to supplement that and not duplicate it or try to build off of that. And so data sharing is always an issue when you're dealing with multiple agencies, city, state, and HIPAA and all of those things. But that should not be a barrier because you can't support street homeless individuals if you're not sharing information. And so we work hard to look at what we can share and what's the most important things to communicate to move the needle with individuals, even if we can't give all of the information. So for example, folks who are in the subway system, we can't tell MTA that they have a medical diagnosis. So when we're trying to get information from MTA about how often they've seen someone, we'll say the person is connected to services, right? Because we want MTA to alert us when they see the person so our team can go out and connect with them. So there has to be an information exchange, but we don't allow limitations on data to be used to prevent us from coordinating and doing the best we can to connect people to services.
How is the city coordinating city and state street-facing programs to avoid duplication of services and canvassing coverage, while facilitating ways to share case-level information across programs?
That's an easy one for BronxWorks, since we have both contracts. So I think Cassandra's probably can better answer that question on a citywide basis. But again, in the Bronx, our SOS team can go into the subway system. You know, they have access to, you know, to the various systems that they need to have access to. And, you know, our DHS-funded team is a service-funded team. What's really been great about SOS is it does give us the ability to provide more intensive follow-up care. I will say SOS teams are not IMT or ACT teams, which are even more intensive, and they have, our SOS team actually has part-time psychiatry as part of it, but they are not the same things, and IMT and ACT teams are much more intensive.
So for DHS, we have our contracted outreach providers who are, again, BronxWorks, BG, MOC, BRC, and Project Hospitality. And so their job is really to build a rapport and have the long-term relationship with individuals. The city's staff is rapid response. So we're the people who do rapid response when there are calls from local officials, City Hall, access 311 calls from the public, street homeless encampments. And so the city staff do not do the same work that the contractor outreach providers, in that there's a difference in the requirements. We're a rapid response for immediate situations that arise and to offer beds in immediate. But anyone that is picked up by a DHS employee is then connected to one of our contracted outreach teams. So for example, if we get a call and BronxWorks doesn't respond and DHS responds, if that client comes inside, that client would not be a DHS client. That client would be added to BronxWorks caseload so that they can get the support that a contracted outreach team has. In terms of the work that happens with the state, the SOS teams, Tracy's team, we are in contact twice a week in meetings, and then we get a schedule every week that lets us know where their teams are at. So we're aware of where they're at, that way we're not duplicating services at the same time. What we found in 2020 is that a lot of times people shared that they felt that they were not getting enough connections to outreach. And so the goal of these additional outreach services is to be there to offer resources in the event that someone is ready at that moment, but the goal is not to duplicate. So with the DOHMH services, you have the IMT, the intense mobile treatment plans, and those folks, they focus on mental health and substance use. So what we do at DHS is really try to make sure that all of the entities that are working with the individuals that are known to us have some sort of coordination of services, and we're often the ones working with each group. So we're working with SOS, or we're working with the contractor outreach providers, or we work hand in hand consistently with DOHMH to know what joint outreach operations we need to cover and which folks they're working with. And our goal really has been to ensure that there are not gaps in the services, because we have clients, some of our most vulnerable, who actually are working with both an IMT team, an SOS team, and BronxWorks, because the level of care that that person needs is required. And so when we're aware of that, we'll go to BronxWorks and say, hey, does this person have an IMT team? And BronxWorks will say, well, they're on a wait list. So then we're working with DOHMH to make sure that this person is no longer on a wait list. Or SOS is encountering a person, and now the person is going to go into a psychiatric setting. Those SOS teams are instrumental in working with the hospitals to ensure that the person then transitions to the long-term psychiatric care. So while the work is similar, everyone has their niche area, and what we've been able to do is to coordinate the services of all the different entities to ensure that there's a continuum that is unprecedented.
While it's great that we have more capacity for outreach teams, there are still barriers to accessing supportive housing. That's kind of the elephant in the room, is the fact that we don't have enough, or people are not being connected to housing. Can you describe the collaboration with coordinated entry and supportive housing providers? This is also in combination with there are thousands of vacant apartments in New York City. How much of this problem would go away if New York City would simply provide more people with their own apartments?
I'd like to answer that last question.
Yes.
Partly because here's a dirty little secret that a lot of New Yorkers don't realize. We actually have more vacant apartments in New York City than we have homeless people. If this problem would largely go away, pretty much, if not, or at the very least, a big chunk of it would go away if we actually housed homeless people in their own apartments. That is something that is, and that should really shake you to your core when you realize that statistic. And it's not just, and let me just say this, it's not just, that statistic is not just limited here to New York City. It's actually relevant pretty much across the entire country. We could basically, there are, I think, for every homeless person in America, there are, I think, 3 vacant residences that they could go into. So it's not something that we can. So it's not a problem that homelessness in America, not just New York City, but in America as a whole, is not a problem that seems as insurmountable as it looks on its face. And that's just all I can say right now. Thank you.
BronxWorks, one of the things we do is we do provide supportive housing to people with serious mental illness, and we more recently opened up a facility that actually takes H&H referrals, health and hospital referrals. So everybody who's moving into these new apartments are people who frequent city hospitals, and we're trying to figure out, that program as well. I completely agree that there needs to be more supportive housing for single individuals in New York. We turn out tons of applications for supportive housing every year. We do well over 200. There's just not enough availability. We are involved in a number of different projects, including Bronx Point, which is the building where the Hip Hop Museum is being stationed. We worked with the developer. We're part of the project there. That project will actually have, I think, close to 100 units of supportive housing in it. So I think there's more and more supportive housing coming online all the time, and and we're proud to be a part of that process. I also want to say something about supportive housing. Is not everybody is a great fit for every type of unit. So there's congregate supportive housing where maybe a building, 60% of the units in the building are set aside for formerly homeless people. There's scattered site supportive housing. Within scattered site supportive housing, there's some projects where that not-for-profit organization like BronxWorks holds the lease, and there's other types of projects where the tenant holds the lease. And all the different types of supportive housing have their pros and cons to them. And it's really, again, it's essential that the outreach staff or the shelter staff or whoever really understands the needs of the clients. Sometimes congregate settings where the supportive housing provider is willing to be the representative payee if the client needs that, or is willing to step in and help the client manage their prescriptions and medications, that's absolutely essential for some of our most vulnerable clients, where we have other clients that can live much more independently. Another thing on supportive housing, there's lots of conversation about this, about clients with serious mental illness, and that's appropriate. But we've seen this surge in people who are really struggling with addiction, especially addiction with opioids. And there's just not enough supportive housing for people who are struggling with addiction. And that's something that I think we really need to put some thought into. I mean, our supportive housing programs, I think everybody who runs these types of programs, we've been plagued with fatal overdoses. Figuring out how to keep people safe in these settings, is something that I think we really need to focus on in the coming years and try to improve.
From a health provider perspective, again, there is a lack of understanding of what supportive housing is or that it's even an option. When I first started learning about the housing landscape, I was very confused as to what supportive housing actually meant. All the New York agreements are very confusing. ESHI, like all those different terms, right? Again, with the terms, it's very confusing. And how can you think about a person's long-term trajectory without understanding what routes we should be pursuing in any given moment? So, supportive housing, one of the challenges to the 2010 e-application is often getting a psychiatric evaluation done. There is a dearth of providers that are able to do that, and not only able to do that, but do it in the nuanced way that it requires. Nuanced, person-centered, get it in a way that will actually help that person achieve that supportive housing. Even before that, we also have to consider other housing opportunities that that person may want or be qualified for. We've been considering assisted living facilities in some cases. We think about how to best support people using their vouchers. Source of income discrimination is still a huge problem, and I know that the city has invested some money coming up to support the source of income discrimination unit. But all of those are different routes of housing that, as a doctor, it would actually be, as a healthcare team, it would actually be really helpful to discern and to know how to pursue that. One other thing is that who is holding on to these applications? In a lot of cases, there's so many different teams working with people, and you're wondering who's going to actually submit that 2010 e-application to CAPS. If I get the psych eval, who's going to follow up on that? So I think that's something also worth addressing.
Thank you. Lots of learning collaboratives.
Excellent, thank you. The next question that we have, this is for Mr. Walker, but also to anybody. Do you think the increase of different outreach workers make it harder for people living on the street to build trusting relationships because they are constantly seeing different people?
In a way, yes. And you have various organizations. For those who don't know, we have a plethora of homeless services providers out there, from CUCS and Breaking Ground to BRC and the Manhattan Outreach Consortium. So you see vans of various folks all over the 5 boroughs, especially when you're out in Manhattan, but also to, so it does. So when you have different teams, different goals. They might be some folks might just offer you a placement in a congregate shelter. Who wants that? Maybe some might, if you're lucky, you might get someone who can get you a stabilization bed. But even then, it may not be something to your liking. I actually had a client a few months ago who got approved for a stabilization bed, but turned it down because it was in a congregate setting. So she was not particularly happy about that. And that is a big blow to someone's trust because you trusted this person. So yeah, I can definitely understand why there could be concerns when you have so many different organizations out there. And I hope that answers the question satisfactorily. Okay.
Wonderful. We have time for one more question. I'm trying to hit on a lot of different topics here. So much of the work of caring for people experiencing homelessness seems to require not just building, but sustaining relationships across health and housing systems. It seems like the complexity is crying out for an entity that would be responsible for the health of people experiencing homelessness, including educating medical residents about services available. Who is or should be responsible for maintaining coordination and education across systems?
I think I can answer that question. I think, like I said, because I don't think that should be the realm of any one agency in the city or the state. I think that should be something that should be a responsibility spread around to various organizations, especially at the public sector, that could address that. Certainly, the Department of Homeless Services should take the lead on it, but you should also have. H&H should also have a role, should play a very big role in this as well. And I guess you could also, depending on the demographics, you may also want to consider the Department of the Aging or the Department, or even the Department of Education, because remember, we have a lot of children who are being uprooted, especially who are either out on the streets or even if they're in the shelter system, could get uprooted and transferred with their families to another shelter outside of their school district. So. This is a multi-pronged. That kind of approach should be multi-pronged, multifaceted, and should be as diverse in thinking as possible.
And I'll let Dr. Shin speak as well. But one of the things we're most proud of with our collaboration with Care for the Homeless over the years is that Einstein School of Medicine now has a whole focus on training providers to work with the homeless population. And Dr. Littleton has been a key part of that. And we're seeing people who've come out of that program that have actually ended up working in other homeless support organizations. So I think, providing opportunities for medical students and residents to really know the population is a key thing. I also know our other partner, Janian and CUCS, I know that they have a collaboration with a medical school as well. I will say my youngest daughter is a physician. I remember when she's an OBGYN now, and her internship was with Planned Parenthood, and it really changed the trajectory of what she wanted to do. So, from a personal family perspective, I know how important it is to be able to expose, medical students and residents to this population. It can really change careers.
It's a lot of responsibility to answer that question for the whole system, but we do it locally at Woodhull. We try as much as we can to explain how we work and just from experience and talk about the things that we think are important. I give lectures to med students and residents about homelessness healthcare. We actually have one of the homelessness healthcare fellows working in our clinic as a primary care doctor and street provider. To scale that, I don't know. I think it involves more than just med students and residents. I think, at its base, kind of like maintaining the open relationships that many of our organizations have is really important, and kind of encouraging us not to guard that information because it's just useful to one player, I think is a really big aspect to it, to create the culture of safety, to be able to speak to people from other organizations, to share, knowledge and hacks that you've learned. I say hacks, but it's like there's tips and tricks in such a complicated system. So I think encouraging people to share that.
Yeah. Sharing is definitely caring. And I think we have one last one, right?
Yeah. Okay. I couldn't turn it on. We had a couple different iterations of this one, so let's try this. How is the administration preparing and planning to respond to the possibility of a larger number of people living on the street should the right to shelter be rescinded?
Righteous shelter.
Okay. A little background. Right to shelter was instituted in 1979 with Callahan versus Carey, the New York State Supreme Court decision that basically encoded into the consent decree to provide a bed to any homeless person who requests it. That has been that basically has been come under attack with this new administration, and I don't mean to disrespect Ms. White Hemphill. I know you work for the city, but this is something that we should call it like we see it. And that has come under attack with this new with the Adams administration. It is also, and combine that with the fact that we have migrants coming in from various parts of Latin America, namely Colombia and Venezuela, who are being put in these migrant centers, some in Brooklyn, some in Queens. I think there's one in Manhattan. They tried to put one out in Ward's Island. And on top of that, you are now seeing folks who are getting notices after 30 or 60 days that they have to leave the shelter and go back to wherever they were, they had originally requested shelter to find a new placement. This is something that has been, to be honest, it should not sit well with anyone with a conscience. It is very, very heartbreaking to hear this, because this is a city, like I said, we probably have more vacant apartments than we have homeless folks, and we could probably house every one of them. But at the same token, and it's very important and I think it's very important that we make a distinction very clear. New York City right now has a right to shelter. We do not have a right to housing, and I think it's very important that we make that distinction very clear, because it really does impact the nature of the work that we're doing. And with the right to shelter, we should make sure that it is still, as imperfect as it is, that it still remain the law in New York City. And I apologize for rambling.
No, that's great. Else want to comment on? Yeah.
So I want to say that the city is dealing with an unprecedented humanitarian crisis, but as a native New Yorker, I'm actually really proud of the way New York welcomed our migrant brothers and sisters to the city. I think the city has stepped up and continues to step up. I think that the city is right now in a space where they're working through what to do when you've reached your peak. I think one of the things that the city did that really made a difference was understand that this is not just a DHS issue, because this is a humanitarian crisis, and they brought other city agencies to the table to help support this. I know that there are a lot of things and a lot of conversations happening about what the next steps will be, but New York is really committed to stepping up, as we already have done, and I think the goal really is to figure out how to connect people to the next step in this journey. And one of the things that was brought to my attention yesterday during a meeting with my peers who run the shelter system for single adults and families with children is that one of the things that have been a good opportunity that they did not necessarily know would be is the fact that folks are now being connected to other locations. Folks are now able to take the City for HEBS voucher and go outside of New York City. So there's a lot of conversations happening about how we move from having people in shelter to connecting the migrant folks who came here to the next step in this journey. Because we know the city's shelter system is not a permanent system. It is not a long-term system. It is supposed to be a stopgap. And so I think that what they're looking to do with our migrant brothers and sisters is to try to connect them to opportunities that will be a more stable and long-term solution to the situation. But there are constant conversations, iterations, and hundreds of hours of meetings every week to talk about solutions, opportunities, and ways that we can bridge folks to the next best thing. And unfortunately, the city shelter system really has reached its capacity, and we have to be even more creative than we've been in the past.
I just wanted to say this. I've worked with a couple of folks who are homeless, especially out in Brooklyn, where there is a migrant center just adjacent to the BQE, the Brooklyn Queens Expressway. And folks I've spoken to say they would not go in. They've gotten those notices, those 30 or 60-day notices, saying that they have to leave and reapply and they're being told to go to the Roosevelt Hotel. Folks at the Roosevelt Hotel say there's nothing we can do. So this is a vicious cycle. And as for in addition to that, they are also talking about the questionable conditions that they're being put to in terms of the migrant centers as well. So it should give us pause to say, yes, we should, yes, the shelter system was designed to be a stopgap, but on that same token, we also have folks who have been in the shelter system. I actually have a former friend and former colleague of mine who actually just got our own place a little over a year ago, but had been in the shelter system since the days of Superstorm Sandy. So you can do the math. Yeah. And it should serve, again, this should be some things that give folks pause regarding about the nature of homelessness, and not just street outreach, but homelessness in New York City as a whole. Thank you.
Thank you. And I'm sure I can keep on talking about this. I'm sure y'all can, and with all the questions, I'm sure y'all can. But our time is up. I want to thank our panelists, Karim Walker, Cassandra White Hemphill, Dr. Michael Shen, and Scott Atwater for this conversation.
Thank you all for being with us for this event. The question of when to compel someone to get a psychiatric evaluation is probably among the more complicated decisions that any of us who do this work makes. And so we put together a panel of true experts who bring different perspectives to this question, and I'm very proud to introduce them to you this morning. Brian Stetton is the Senior Advisor on Severe Mental Illness to the administration of Mayor Eric Adams. From 2009 to 2022, Brian was the Policy Director of the Treatment Advocacy Center. In 1999, while serving as Assistant New York State Attorney General, Brian drafted the original proposal for Kendra's Law, which authorized assisted outpatient treatment in New York, which is a relatively unique intervention in New York. It's in place in other places as well, but New York was the place that kicked it off. And that was a program trying to help people living with severe mental illness who were struggling with treatment adherence. We're also very grateful that probably the farthest traveling panelist, Dr. Eileen Riley, is with us this morning. Dr. Riley has dedicated her professional career to caring for people experiencing homelessness. She currently works for the Massachusetts Department of Mental Health at the Massachusetts Mental Health Center and at Boston Healthcare for the Homeless, our sister organization and great friends and colleagues in Boston under the leadership of Dr. Jim O'Connell, one of my personal heroes. And she's rendered care at Boston's Pine Street Inn, that I'm sure many of you know about, the St. Francis House, Women's Lunch Place, and specifically, and I think relevant to this panel, serving folks living on the streets of Boston. Kimberly Blair, who is also joining us this morning, is the Director of Public Policy and Advocacy for NAMI New York City, National Alliance for Mental Illness, for those of you who don't know, where she recruits, trains, and leads a group of nearly 200 ambassadors in grassroots advocacy efforts to increase access to mental health care, to decriminalize mental illness, and to promote mental health education for students and teachers, among other projects that she works on there. And we're particularly pleased this morning to be joined by the Honorable Tiffany Caban, who is the councilperson who serves District 22, largely Queens. Before joining the City Council, Councilmember Caban worked as a public defender, representing people who did not have resources to defend themselves against the brutal system of mass incarceration. And through her professional career, she has used the law to help New York City's most vulnerable communities. So we're very honored to have Councilmember Caban with us this morning. I want to start and frame the panel with a brief anecdote, because I think that this says something about what we need to figure out this morning in this discussion that we're going to have. I live in Brooklyn, next to Prospect Park, and about 7 years ago, a gentleman took up residency in our subway station and lived there for about 4 years. He was there probably 300 out of 365 days of the year, 5 at least out of 7 days in the week. He didn't have any obvious means of support. I'm not even certain how he fed himself. He wore the same clothes, whether it was August or February. He would wear very, very filthy clothes, generally with a hood, wore goggles. And if that person had been aggressive or violent, we would have had a set of tools to address him, to address that issue and to help him get access to care. But he was beatific. He would sit there and smile, occasionally talking to himself or people we couldn't see. But he was calm, beatific, never threatened anyone. And if, again, he was a person who was engaged in aggressive behavior, the outreach teams would have had a set of tools with which to work with him. But I think the question of him being in that subway station raises 4 fundamental issues for us this morning. One is, what are our responsibilities as citizens of New York City to people who are living like this on the street? Is it appropriate that we just simply walk by and not do anything? The second is kind of the countervailing question, right? What civil rights does he have to be in that condition? Does he have the right to self-determination? Now, I'm not a psychiatrist. I wouldn't diagnose him, but I think it was fair to assume that he was living with a serious mental illness. What rights should he have to self-determination, at least without trying some kind of treatment regimen? The third question that's essential is, this is a person likely, again, I'm engaging in some stereotyping, but we're probably close to true, probably experienced significant trauma in his life. And would the process of moving him involuntarily to an emergency department or inpatient bed contribute to increasing that trauma? That's a very important question we need to ask in any of these situations. And then finally, moving someone to an emergency department or an inpatient bed is not the outcome we're seeking, right? That's the beginning of the process. So what is the constellation of services that will help that person make progress in his or her life and not return to that situation? And we really have an incredibly talented panel this morning to address those questions. I do want to make one kind of apology as we begin. Nomenclature is important, and so we're going to talk today about involuntary removals, and I really hate that term. I feel like you're talking about an object, not a person, and so, but that is the term of art, or, you know, a series of terms of that nature. So I do want to apologize in advance that we may use language that is not appropriate to the magnitude and the importance of what we're discussing, but you may hear language like involuntary removals or involuntary removal orders, and just wanted to acknowledge that up front. So, as I said, if this individual I mentioned had been violent or aggressive, there would have been a set of tools that we had access to, and Scott Auerwater from the previous panel addressed some of those, the 958 capacity that the outreach teams have as designations as mobile crisis teams. And so I want to start with Brian this morning. And Brian, if you would kind of level set for us, what was the state of the art with respect to the ability of a mental health team to compel someone to receive an evaluation at a hospital? And Mayor Adams has, within the last year or so, changed the rules, so to speak, or broadened the definition of people who might be subjected to that intervention. So if you could just give us the baseline, where we were and where are we now?
Sure. Thank you so much, George. And Good morning, everybody. So great to be with you. So, thanks to Care for the Homeless and BronxWorks for putting this terrific event together. I think it's really important to understand, first of all, something I think is probably obvious to most people in this room. The mayor did not create or establish the policy of involuntary removal of people who are in psychiatric crisis in the community. That's a long-standing and routine function of city government here and anywhere else in the U.S. you may go. We did not even actually change or broaden the policy, I think is a really important thing to note as well. It's not that there was a previous policy that said that we can only have these interventions under X set of circumstances, and we've now said disregard previous policy, it's now X plus Y. We're doing something broader than you were able to do before, where we're kind of changing the authority that police officers, law enforcement officers, and mobile crisis clinicians have always had. Instead, I think what we've done, the better way to understand this, is to say that we have filled an information vacuum, right? We have attempted through information and education and training and kind of repeating of messaging to correct a pervasive misunderstanding that has resulted tragically in lots of situations where we have had opportunities to help people to escape or tragic circumstances and a horrific fate, but didn't think we did because of the way the law had been misunderstood. And I'll say more in detail about that in a moment, but I think it's kind of important up front to just kind of set what the philosophical underpinnings of this culture shift that we're attempting to bring about are. And there's two aspects to it. One I think is kind of grimly realistic, and another that's extremely idealistic and optimistic. And the grim reality part of it is just the recognition of the existence of anosognosia, right? Lack of insight, as a really cruel corollary of severe mental illness for lots of people. Not everybody who suffers from the most severe psychotic disorders experiences anosognosia, which is a neurological syndrome that actually prevents a person from recognizing that they have an illness and have a need for treatment, no matter how painfully obvious that may be to everybody around them. And when we encounter anosognosia, the reality is that our attempts to engage that person to come inside on a voluntary basis, to come to the hospital for an evaluation, perhaps to admit themselves, it's not, in many cases, it's simply not going to happen. And we're going to do everything we can to bring that about, but also recognize there are folks who cannot get there by no fault of their own. It's a part of their illness that they cannot see what is happening to them and the reason for it. So, that's the kind of unpleasant part of it that I just think we have a moral obligation to acknowledge and deal with. But the idealistic part of this is just a real belief that treatment works and that there are remarkable transformations of folks that are possible. And you heard Scott talk about some of that that's actually happening now when we get somebody on a treatment track. But it has to start with getting them to a hospital, and if they meet the criteria, to actually admit them to the hospital and hang on to them long enough to stabilize them, get the meds right, help them learn some habits of treatment engagement, and do all that work that was talked about in the first panel to set them on a course where we can get them back into the community in a supportive housing environment. That's what this is about. This is about rescuing people from awful circumstances and a really terrible fate. So what then is the pervasive misunderstanding that has been preventing us from doing this in so many cases over the years? It's really about the way the law has been interpreted, right? So in New York, as in every state, we have a basic standard that a person has to be a danger to themselves or others. The actual language of the law is that the person represents a risk of serious harm as a result of their mental illness. And that language is uniform around the country, but what I think makes New York unusual, unlike 47 other states, is that we don't have really specific definition of what it means to be a danger to yourself or others in the law itself. And so this has led to it's in the eye of the beholder situation where the law has been interpreted in a certain way. And the danger to others part, I think, is reasonably straightforward and obvious what it means to be a danger to others. But danger to self is where we have seen some really unfortunate missed opportunities. And that is because danger to self is often interpreted to mean, again, not rooted in the language of the law itself. It's interpreted to mean that you are presenting some risk of imminent harm to yourself. So you're suicidal, or you're engaging in some outrageously dangerous conduct, such as running into traffic or trying to fly off a rooftop, or you have some imminent medical need that if it's not addressed immediately and you can't recognize it, you could die, or it's a freezing cold night and you're going to have hypothermia if we don't get you off the street. All those are situations where I think it's generally been understood that a person's a danger to themselves. But what that has missed is a whole swath of folks, very much like the person you're describing, right, in the Prospect Park subway station, who are a danger to themselves in the sense that their mental illness is preventing them from meeting their basic human needs of food, clothing, shelter, medical care, such that they may not pose an imminent risk of harm to themselves, but they pose a very real and predictable one, and they are headed for disaster. And so when we're observing people in this situation, and I've been out, certainly before this policy shift, this culture shift was announced, I spent a lot of time with our end-of-line operations in the subway stations, with several of our outreach providers, including BronxWorks. Spent a lot of time on the calls that Cassandra talked about this morning, our Coordinated Behavioral Health Task Force, and heard a whole lot of hand-wringing and a lot of literal walking away from people who did meet the legal standard as it has been interpreted by the courts. But because of this narrow interpretation, people thought we couldn't help them, and actually wanted to help, but thought we couldn't. And the case law is actually pretty clear on this. There are cases. The landmark one is the Billy Boggs case from the 80s, but others that have interpreted it since, that make pretty clear that an inability to meet your basic needs, when it's connected to the mental illness, is grounds for removal and it's grounds for admission to the hospital. So that, I think, is what we have been trying to instill, and we'll talk more about how that has worked out, but that's the philosophical basis for it.
Thank you, Brian. Councilmember, you, I know, have studied the response of many cities in your due diligence thinking about this issue and how they've responded to these similar issues. And you're a person who spent her career protecting poor people from inappropriate intrusions from government. So I don't mean to put words in your mouth, but what is your reaction to this change in policy, and what do you think is working and what do you think is not?
I mean, I have lots of thoughts on this, and I want to frame it from a place of I am somebody who is living with a mental health diagnosis. I am somebody who has represented hundreds, well over 1,000 clients, the vast majority of which are living with a mental health diagnosis, and quite often a serious mental illness diagnosis. And I will say, with all due respect, I'm going to be a bit critical here. This idea that the mayor has not changed the law certainly is influencing the degree to which that law is being used, leveraged, signaling to NYPD and other agency infrastructure how it should be approached. And personally, I will say I'm more of a fan of the proposed Daniels law than I am of Kendra's law. But I will say, a lot of the rhetoric we have seen from leadership in the mayor is this idea of who is, and I'm going to hit a few of the pieces that were talked about, but this idea of dangerous behavior or not. And I think that's an important point of discussion, because if you listen to the mayor, and in some of his interviews, he has said, well, you see the guy shadowboxing on the street, that's dangerous. That's not dangerous. You see somebody yelling to themselves on the street, that's dangerous. That's not dangerous behavior. And I have had the opportunity to travel to different places, Portland, to be on site with the Portland Street Response Team, to stand in the middle of dispatch and watch how they're dealing with and routing these calls, to go to Denver and look at what they're doing with the Denver Star program. And when I was in Portland, I had this really great story that is a good example, but one of the Portland Street Response Team members said, a fundamental difference about a peer and a mental health responder is that we are going to look at a situation and interpret it a lot differently than a lot of other folks are, whether they are EMS, whether they're police, whoever it might be. And they said, we had a gentleman, for example, that we got a call for, chronically homeless, living with an SMI, and they called us, and he was out on the street, hanging out, sitting on the sidewalk. And the report that we had gotten was that the gentleman had a bunch of rocks in his pocket. Well, the police officer that was part of this panel, the deputy sergeant that was part of this panel with us said, I'm going to be really honest with you. We approached the scene and that's a weapon to us. We're going to go in as though that is a person who is dangerous with a weapon. But Portland Street Response Team stopped us and said, no, we got this. We actually feel safe. We don't think that this is a threat. And they walked over, talked to the person, sat down on their level, which the police officers after the fact were like, we would never do that. And they were like, we know you wouldn't, but I don't feel threatened by this. I'm gonna sit down, talked with that person until one by one, he took rock after rock out of his pocket. And they were able to triage and care for that person with his immediate needs in that moment and move on. But if you have policy instructions or an interpretation of a law that takes behavior and consistently and chronically mischaracterizes it, cutting off the avenue of lesser intrusions and actually like care-forward responses, you're gonna get different results in different places, and that is why we are seeing different results in Portland, in Denver, as opposed to what we're seeing here with BHERD, which I want to be really clear. I'm really glad we have it. It's a good thing to build on, and I think there are ways to strengthen and make it better. I also want to contend with this idea that treatment is not, and kind of challenge that I don't think treatment is idealistic. I think it's empirically proven to work better, right? And so it's a reality and a not just a moral imperative, but in terms of public health and public safety outcomes, a health and safety imperative. And so, I think the framework that we use when we're approaching communities and trying to solve these problems really informs the way we go about ideating policy solutions and executing and enacting those policy solutions. And I'll give you one more example. And again, I want to apologize because I'm nitpicking a little bit. But we're not rescuing folks. The fact is that we live in an ableist society that has shut folks out of being able to access basic human dignities, right? That a lot of us who are quote unquote different functioning or higher functioning or aren't at the intersection of the disability community, at the communities of color and all of these things. And so when we go in and implement these practices, it is about dismantling ableist infrastructure and saying that we are going to create more inclusive infrastructure that doesn't completely leave out different folks. So I think the approach is really important. The last thing that I want to highlight is, trying to keep in mind that when we talk about responses, and also just, again, wherever we can, even if it takes 2, 3, 4, 5 touches to get somebody voluntary treatment, I believe is always going to be the better option than exerting an involuntary commitment, with the understanding that there might come that extreme where you have exhausted things and it really is necessary. But I think we should be taking some different approaches and understanding that it's a response. And so when we talk about alternative mental health responses, yes, we need them. It is critical in moving in the right direction, but let's not pretend that it's the be-all, end-all. It's still a reactive response, and it has to be done in conjunction with building out a full continuum of care infrastructure. Like, the goal should be not just better outcomes when we're responding to people experiencing a mental health challenge or a mental health episode on the street, but the goal actually should be to lessen the number of calls we get for that situation because people have access to a continuum of care. And the last really big difference between some of the things I've seen around the country, and this has everything to do with policy and policy approach, is you have to have places to take people. We don't have enough places outside of an emergency room and a jail cell in New York City to take people to get better results on the alternative mental health response with that strategy. You see in other places that there are some better infrastructure options and more options of taking places, and there aren't policies that are gonna put people at risk, and I promise I'm wrapping in 30 seconds, but I'll give you an example. When you put the mayor's policy together and the directives on this together to use this law to its fullest extent, for example, and you put that together with this policy of sweeps on homeless populations, it's a disaster and it flies in the face of best practices. And I'll give you another example. If a Denver Star team participant or a Portland Street Response team participant goes out, I'm going to give you another scenario, which is a common scenario. There's somebody who is experiencing homelessness, maybe neurodivergent, or has some sort of mental health diagnosis, sitting on somebody's stoop, right? They're on somebody's property, the person doesn't want them there, so they get a call, the alternative responder comes, and the individual doesn't want to go to a shelter, doesn't want to go to a hospital, doesn't want to go to the place. So they ask him in that moment, well, where do you want to go? We'll take you wherever you want. Wherever you feel the safest, most comfortable, we'll set you up with a cup of coffee. You want something to eat, we'll get you something to eat. Are you good clothing-wise? We got you. Where do you feel safest? And the gentleman said, well, I have this park, there's a tree that I really like to sit on. They will take you to that tree that you really like to sit under because you feel safe there. And under current policy, that kind of being in that space, right, or maintaining presence in a space like that could end up getting you swept up by the police. And so you're seeing how different policies intersect and actually end up being really counterproductive. Would you prefer to have this person, again, with somebody who now doesn't have to worry about that person unwanted, whether it's right or wrong, sitting on their stoop. We don't have that person agitated or in more distress because you didn't force them to be somewhere they didn't want to be. And then knowing that this is this person's favorite place to go, now that outreach team knows that I can keep going back to that place, keep having conversations with this person, build a relationship, and at some point he might be ready to enter some kind of treatment or access a continuum of care. And all of those things matter.
Thank you. Dr. Riley, you're the only person on the panel, I don't mean to put you on the spot, who's actually been called upon to make the call, to say that someone is sufficiently in danger that they need to go to the hospital, whether they want to or not. We're going to put a point on it. You've also done this for a long time. What do you see, has your viewpoint on this changed over the years of doing this actual work? What light can you shed on this very real debate about where we balance the policy directives? I mean, you're not initiating a policy directive. You're making a call as a doctor. What can you tell us about this?
So I've been working as a psychiatrist on the street for 20 years, and I work with Department of Mental Health, who's really involved with homelessness, which is really fantastic, really helpful for us, because they're really responsible for people with severe mental illness and have a responsibility to take care of people and to eventually house people. We like Brian was talking about, Massachusetts has a narrow interpretation of danger to self, so that and I'm really interested in what's going to happen in New York with this involuntary removal policy. Because what we have to do in Boston is wait for people to be pretty desperate before they get hospitalized. Lots of times we have to wait. We see people really suffering on the street, not doing well, not eating well, and unable to care for basic needs like get clothing and get food. And it breaks our heart, especially when I go home at night and it's 10 degrees, and I'm thinking about my warm house and about a 70-year-old woman lying on the sidewalk. So we work with teams, and if we do decide to involuntarily hospitalize someone, we kind of try to come to a consensus. So if there's an outreach worker that we know who has a really good relationship with the person and says, this person's really close to accepting a safe haven bed, for example, then, we'll hold off. But usually and again, we have to wait till people are, in imminent danger. So usually we wait until someone is out in the cold and is at risk for hypothermia. Or we wait until people have medical illnesses. We have several women outside who have leg infections. So when they need medical treatment for their infections, then we can send them to the hospital. We had a man who was outside for 20 years, and we loved him. He's really charming. We'd bring him tea and coffee rolls, and but I'd say to myself, what are we waiting for? This poor guy should, he would probably do well in housing, but he was actually too disorganized. He couldn't really have a rational conversation about getting into a safe haven bed or getting into a DMH shelter. So he was surrounded by, he was by a college, and a lot of the college kids would give him food, but they'd bring him like a dozen donuts, or like 16 packages of cookies. So he wouldn't throw the food away. So he would be surrounded by food, and then rats came. I just thought, we really need to help this person. So he got bitten by a rat. So we used that as an excuse or a reason to get him hospitalized. He ended up doing really well. He was there, the hospital, he was at McLean Hospital, which is sort of a famous hospital. We were thrilled that he got admitted there. But the staff took really good care of him. They talked him into taking medication so they didn't have to go to court and get a medication order. But he kept telling them that he was going to get discharged and go to Saudi Arabia. He didn't know anything about Saudi Arabia and had no connection. But it was a delusion. And so we were really worried he would return to the street. And when people are hospitalized, our teams go and visit the person. We bring them treats. We talk to the staff. We meet with the person and the staff to sort of see where the person is at in terms of accepting an alternative to the street. So he was there for 2 months, and the medication worked. And then he said, we were telling him that we have a DMH shelter that he can go to right downtown. And he finally said, okay. So we went there, and he's still there. He's doing really well. He goes to the day program. He's the star of the day program. Everybody loves him. He gets in Vegas, Sustena, which is a monthly shot that has really helped him to, be able to have relationships and enjoy the day program and to stay housed.
Thank you. Kimberly, you have an extensive career advocating around mental health programs, and I'm interested in your perspective. The Councilwoman, not to put words in your mouth, but one of my summaries of your comments is that there are missing parts of the continuum of care. So if these things are not in place, we're like jumping to involuntary hospitalization when other things might be effective that should be tried certainly first. Maybe never do it, but certainly there are other things that we should try first. What, from your perch overlooking the mental health system, is missing that would help us? And by the way, I do want to, Scott Auerwater made the point earlier that this is a very rare instance, and I think that by anyone's reckoning, the number of instances in which someone is actually compelled to receive an evaluation or treatment, very, very small vis-a-vis the total homeless population. But obviously, we could perceive that as a failure of more upstream programs. So what's missing from the mental health system that you think would be helpful to make certain that these kinds of removals are rare and infrequent?
Thank you so much. First, before I answer your question, what I'd like to really I think it's important to just come out and understand and contextualize. My background is not because I went to fancy schools. It's not because I'm the director of the National Alliance on Mental Illness of NYC's public policy program. It's because I'm someone who lives with serious mental illness. At the age of 5, I was court ordered to get a psych eval because of the symptoms that I was experiencing. So I know firsthand, maybe not what it's like to be involuntarily transported to a hospital, but to be forced to sit with a doctor and that doctor really not understand your cultural beliefs, where you're coming from, and why it is that you are exhibiting some symptoms, okay? And that was here in New York. So that was 3 decades ago, or, I'm actually not gonna tell you.
Wasn't that long ago.
But I will note that not much has actually changed, right? So what we're seeing right now is that instead of seeing involuntary as what it was designed as a last resort mechanism for certain cases where people are a danger to themselves or others, we're using that as a first response intervention. As a public health person, that's not really the greatest approach. What we're missing are peer outreach teams. My organization for over 40 years has focused on peer education, classes, support groups, but not just that. Something crucial that is missing is family and caregiver support, all right? So coming from a peer perspective, what does it mean for me to go through treatment if my social supports around me are not built for success for me, or to understand what I'm going through, what I will need to sustain my recovery? We focus on that at NAMI NYC, but we are seen as treatment adjacent. We are not seen as direct services that we can bill for. Everything comes from, philanthropy almost. And we have tried to make commitments from the city and the state to focus on that family and caregiver support that is necessary, because the first step towards any of the anecdotes that any of you have mentioned today is a deterioration of your social support, your network, your partner, your mother, your father, the people around you who you live with. The first step to being on the streets is usually them not understanding what is going on. Or then we look at systemic issues, right? That's the first inner circle. We move forward to the system, and the system is, you don't have enough money. Everything is out of network in the city. I don't know if you've known. If you have tried to get a therapist during the pandemic, I worked at NAMI NYC. It took me forever to get a therapist. That's a shame, right? So if you can get the therapist, your insurance doesn't cover it. You don't have the money for out-of-network fees, sometimes $400 a session, especially when you're thinking of SMI and some of the nuances in the care and some of the medication that is used off-label, and fail first policies that happen at the state, where you have to fail first on a piece of medication because that's what your insurance wants you to try first, and see you fail and deteriorate until they can cover the real medication that your doctor advised. So when we look at the systems, I commend this city, this administration, for really opening up the dialogue, understanding that there is an issue, that we have a persistent mental health crisis, and our governor for putting forth a lot of different commitments this year, but we're missing wraparound care with supportive housing. Involuntary removals is just a Band-Aid, because guess what? If your policy says one thing, that doesn't necessarily align with what the triage nurse or the charge nurse at the ER's policy is for the psych evaluation as to who can be admitted. So now I'm on one side of the city having a quote, what we failed to define before was that this policy was brought into anybody who can't meet their basic needs can be involuntarily removed. And we have a lack of transparency in data. That's why City Council called for a hearing earlier this year. We don't know, really. Reporters are doing work. That's how we're getting information. We don't know how many NYPD officers are using the hotline to consult with a clinician before determining what constitutes as grounds for involuntary removal, but we do know that the last time we had a report, it was 0. So somebody's just on a hotline getting paid when we could be using that towards resources such as supportive housing with wraparound care. Even with supportive housing, I would like to point everybody to Shout NYC. They're a tenant-led application, tenant-applicant-led also organization. They focus on all the issues with supportive housing. Many of them have serious mental illness. And the quality standards of care are not even inhabitable. You know, they have discriminatory practices to trying to even get into supportive housing, right? So just to wrap up, because I know I'm going on a tangent, I'm sorry, I feel really passionately about this. We need peer-led outreach teams. Peers need to be at every crux, or at every level of interventions. Before this policy was announced, peers should have been consulted because we could have advised against a lot of issues. CBOs could have been consulted. We weren't consulted. City Council, thankfully, before their mental health roadmap, actually did consult many of us because they wanted to get it right in response to what was going on, right? Peer outreach teams, we need that. We need peers on the non-police crisis response lines. We need integration of 988, which for many of you who don't know, 988 is our nation's 3-digit mental health crisis line, all right? We have some issues with that. And no, the city's not working towards fixing that or towards integrating it or even educating the community. My family doesn't know. I live with serious mental illness. What if one day I have dissociative amnesia? That happens to me. They wouldn't know who to call. They wouldn't know that they could call in Spanish, right? So these are the things that we need to be committing our money towards. And they're not things that are easy fixes like removing people and removing their rights to self-determination. And then that way nobody sees the problem on the street. Because the real answer to the problem would take way longer and would be an acknowledgement of this administration of decades of neglect to our community since the deinstitutionalization of psychiatric hospitals. We were supposed to have housing, reintegrated into society, money for care, food, EBT. We don't have these things, and that's why you see us on the street. So I just want to stop there.
Thank you. Brian, what has been the implementation trajectory? What has been implemented? What have the outcomes been? How many times do you have a sense of how many times has it been used and what the outcomes of those instances were?
Yeah, so hard data on that is not something I'm going to be able to share at this point. I hope that's understood. I think we're moving towards a point where we're going to have something more concrete to say. But kind of speaking anecdotally, I would say that, look, there is a reality that to really scale this up to the point where the average New Yorker is really noticing a difference in what they see around them and on the streets and subways is going to take a lot of the investments in building a real continuum of care that the council member and Kimberly, I think, spoke of eloquently, and much of which I agreed with. We do, as Kimberly said, have a mental health system that has been neglected, shamefully neglected for decades, and we do have, I think, some very exciting and promising plans in place to reverse that. It's not going to happen overnight, but our Department of Health and Mental Hygiene has released kind of a grand vision of where we're hoping to go, which includes lots of really important investments, another 8,000 units of supportive housing, another 800 slots for IMT and ACT, increasing the footprint of clubhouses substantially across the city, which we already have an RFP out for now. So yeah, to really make a difference where we have the capacity on a large scale to get the kind of folks we're talking about onto the track of meaningful long-term treatment, that's going to take some time and some investments. What I think we have been able to do in the meantime is some really exciting proof of concept on a reasonably small scale with our Coordinated Behavioral Health Task Force, right? Those two meetings that we have every week, one with about a group of folks who are really well known to the subway system and that BRC works with, and another that are kind of well known in the streets and park environments that our other 4 outreach partners work with, where members of Cassandra's team, work through this list with that group every week, and I'm part of those meetings. And the ability to think more broadly about our ability to help folks and when they actually are presenting a danger to themselves in particular, in a way that we have a reason to take action on, has led to some extraordinary results. And again, because it's on a small scale, we're able to prioritize those folks for the resources we currently have. So that has a lot to do with why we're having success with them. But Scott talked about a couple of the stories before, and it's been, Andy Newman did a story in the Times a couple of months ago. I don't think anyone can deny that there are folks who are getting care, who are reconnected with their families in ways no one thought possible, who are connected with their treatment teams who have been completely alienated from them. We are seeing some results in ways that are exciting to me and that make me know that as we work to solve these larger systemic problems, we're going to get to an even better place. And let me also say, I think it's really unfortunate to me that so much of the debate on this issue and so much of the reason we're always kind of talking past each other is because the arguments have been framed in extremes, right? It's the recovery model versus the medical model. It's self-direction versus completely telling people what they've got to do and imposing everything on them. That's actually not the world we live in. And I don't think it's consistent with what actually our policy as a city is. Involuntary mechanisms of any kind, whether it be Kendra's law, whether it be involuntary removal to a hospital or admitting someone to a hospital when they don't want to be there, is absolutely a last resort. And all of the important things we have to be doing before we get to that point, I think with the limitations of resources we have now, I really do believe we're trying to do. But I do think there's a question that can't really be avoided here, is that what do we do about the person who does not recognize their illness, does not recognize their need for care? They may have a delusion, right, that is driving their presence on the street. They may be sitting in front of their apartment building that they were evicted from 20 years ago because they're waiting for the super who actually moved out and is not even the same super anymore, but they think that particular person has their key and is going to let them in, and that's the thing that they are driven by, and they're not going to leave that spot until that happens. Or they may have had an experience in one of our safe havens where they were convinced that the nonprofit organization operating it was trying to kill them, trying to poison them, poisoning their food, planting devices in the wall. That's the reason they left. When we're engaged with that particular person and we've offered them the best of everything we have, and that's the case of a lot of people on our top 50 list, what do we do then? Do we walk away? Do we say, okay, well, this is just not working, so we're going to have to just let you rot on the street? Or do we recognize that person may be a danger to themselves in a different way than we had been thinking about before? And
Thank you. Councilwoman, I'm going to do the magic wand thought experiment.
Okay.
The Biden administration delivers $100 million to New York City tomorrow. You're in the council, and you need to advise the mayor or come to some agreement with the mayor in terms of what that money should be spent on. What are the 3 top priorities that you would, addressing specifically the kind of person that I set this up with anecdotally, the kind of the person living on the street for a long time, possibly with a serious mental illness? What are the 3 top programs that you would implement with that money?
Ooh, okay, sure. But I think it's worth engaging with what was just said to lead into what I think those investments should be, but also first and foremost, I don't think I'd make a recommendation without demanding having peers at the table to inform the recommendations, should I get such an audience as the president. But I will say that I don't think that when I approach trying to tackle this issue with my laser focus being, again, the best public health and public safety outcomes that provides the level of dignity to each individual that they deserve, that it's about talking about the extremes, because I'm a policy wonk. In my mind, systems should be built for the majority of situations and be flexible and nimble enough to be able to then address an extreme or an outlier. Maybe not to the best efficiency or capacity, but like that is what we build systems to do, and then recognize that we're going to keep trying to get better and better. And so, you know, when I feel like I come to a head or a tension, using the administration or maybe some other folks as an example, it's because I think that what is missing from this infrastructure or plan that's being laid out is one, the obvious thing is that the roadmap sounds nice, but with pegs across the board and 15% more cuts coming down the pipeline, it's an unfunded mandate. And so it sounds nice, but I don't know how we get there. But that there's really a lack of transparency, and that lack of transparency leaves a gap in having a ton of experts, people with lived experience, people who are charged with oversight in our city, the council, for example, to be able to assess the efficacy of a program and be able to have a conversation about how do we get better outcomes and what are actually best practices. So, you know, I'll give you an example, and this has been a frustration of mine, is that we know that by the numbers based on the reports from BHERD, and again, I want to be really clear about this. I am so happy that BHERD exists. I want it to be. BHERD is our alternative mental health response. It started in a couple of areas in the city. It's expanded a little bit. Again, it expanded without more money, so I don't know what that expansion looks like. It really does. And that's also a question about data and transparency. But what we're seeing is that the numbers that we do have, which like a quarterly BHERD report that I looked at recently, I think was like between 8 and 10 pages, the quarterly reports that I've seen for some of these other programs in the country that I've talked to, about 30, 40 pages worth of really, really deep information and data, right? Like that's the kind of under the hood look that we need to, again, be able to strengthen the program, and that doesn't exist at the moment. And the other thing is that even with the limited information that we have available to us, so that we're not just going off of anecdotal stories from folks that are touching the work, but we know that the police are being called in a far higher percentage of calls with our BHERD model. This is just one example, as with then Portland Street Response, then Denver Star, then Cahoots. And so the question I pose is, because I say, well, what's happening here? Because there's too many gaps, I can't see it, because I don't think that anybody can make the argument that people who are experiencing serious mental health issues in New York City are fundamentally so different than people experiencing serious mental illness in other cities around the country that we must have police responding at a higher percentage of the time than they are with these other alternate responses. And so, like, for me to be able to bear that out, whether it's true or not, and I would guess that it is not true, we need more information. And so, you know, the critique that comes from me is like, I want more information. I want there to be, you know, more conversations about actually how this is working, and having more people at the table to make sure that we're getting the best outcomes possible. So if I'm going to ask for 3 big investments, and then I'm going to say like, hey, do you agree with this? I would say, one, really investing in like wraparound infrastructure in terms of expanding, you know, the number of clubhouses, the number of supportive housing that's available, like, which I'm cheating because that's several things. It's like good, permanent public health infrastructure. I would say expanding OPCs 24 hours in every borough. You know, not only do they prevent overdose deaths, and we know that, you know, like, trauma and mental health issues and the inability to treat those things often leads to substance use disorder and contributes to the overdose crisis that we're seeing. But those places are such beautiful places of support and care and dignity that they're a really good way to get people onto a track of like getting a PCP for the first time, being able to wash your clothes. Like, it is just a one-stop shop. So it's a beautiful piece of infrastructure. I'd be like, please fund this in every borough, 24 hours a day. Let's get that done. The other thing is that I really believe that we need to spend a lot of money getting pay parity for like other response workers outside of police. So if you are, thinking about going into response work, you're gonna apply to be a firefighter or a police officer and not an EMT or an EMS worker because you get paid shit. It is not worth it, and we need more people in that line of work. And when I talk about creating that not just pay parity, but expanding, I think the city's job is to create a workforce that meets the city's needs. And so incentivizing and really making it attractive to be like an EMS worker or EMT worker, great, but also peer workers we should be creating a beautiful, robust pipeline so that peers can make a career out of the life-saving work they're already doing for nothing. And that the effect of that is, like, the investment that you're making is making sure that peers who are living and maintaining their health on an everyday basis continue to do so because they're gainfully employed with good insurance, et cetera, and then they're helping other folks, and they are the best people to help other folks. So I think those are the big bucket areas that'd be like, please give me all the money for that.
Thank you. Eileen, what can we learn from Boston? So you're hearing this kind of description of gaps in the continuum of care. What does the continuum of care look like in Boston? What are all the services that someone who you might eventually move into the hospital receives that we can learn from and we can improve their situation before we get to the point where it's a confrontational intervention?
I mentioned Mass Department of Mental Health. About 25 years ago, the director in Boston, the medical director, decided that he didn't know much about homelessness. And the way that the clinics that served serious mentally ill folks was set up is that people waited in their offices for people to come in. And if they didn't come in 3 times, they would be closed out from the services of the Department of Mental Health. But this physician realized that, people aren't coming in, especially homeless folks. So he visited several shelters in Boston and recognized that there were so many people there who seemed seriously mentally ill, people in the corner of the shelter lobby hallucinating, and people that just seemed really that they needed treatment. So what he did was he assigned psychiatrists hired by the Department of Mental Health to all the shelters in Boston. And then there was money to form a homeless outreach team. So there's a homeless outreach team in Massachusetts paid by the Department of Mental Health, in Boston rather, that goes out on the street and determines who is in need of services of the Department of Mental Health. So we follow those folks pretty closely, and we have 4 Department of Mental Health shelters that are, less chaotic than the city shelters. So we try to invite people who are in the shelters and on the street to come into those shelters. They're much calmer. People are assigned a case manager to immediately start working on a housing plan. And there's a lot of people in the Department of Mental Health shelters who aren't treated and don't want to be treated. Usually they have, inability to recognize their illness that Brian talked about. But, they're doing okay. And some people can get housed without being treated. And then we have rounds with the director of the Department of Mental Health. It's called People Who Are Difficult to Engage rounds. So we talk about people in the shelters and on the street who we've been trying to get, talk into taking a safe haven bed or a Department of Mental Health shelter bed, and that we just can't. So we try to brainstorm. We invite everybody who knows the person, so the primary care physicians, case managers, anybody who is dedicated to that person, dedicated to helping that person. And we kind of brainstorm. Sometimes, we can't really come up with much, but at least we have a chance to focus on that person. And then it reminds us, we have to try to do more outreach, or we have to try to better engage the person. There's someone outside right now who she has a lot of delusions, and I talked to her about going into a safe haven, and she said, "Oh, I'm moving out of Boston next week," and then several months later, she's still in the same spot. But I think constantly bringing up that there's an alternative to the street. The safe havens that we have 8 safe havens, and people get their own bedroom. There's 24-hour staff. They get 3 meals a day. There's no rent. It's pretty welcoming and hospitable. So a lot of people that we think we can't help at all, we can talk into going into the safe haven beds.
Thank you. Kimberly, is there ever a situation where you think compelling someone to receive an evaluation is appropriate, or do you feel this is simply, when we get to that point, it's just failures of previous attempts at interventions or failure to try?
Well, first, I just want to answer by saying I am not Dr. Riley, so I am not a clinical psychologist or psychiatrist who could actually determine that. I think that those people need to be in the room when writing our policy, when working to expand our policies, to narrowly define what constitutes as a danger or an imminent danger to yourself or others. I'm on the steering committee of CCIT at NYC. It stands for Correct Crisis Intervention Today of New York City. I welcome anybody to look at their website. And we have determined some narrow definitions based off of focus groups, based off of clinical studies, based off of the CAHOOTS model for non-police response that's operating out of Eugene, Oregon. And so it is not, even though I am a policy person, it is not my place to actually make that determination without having several different people in the room. And I think that's what the issue is that we're constantly seeing this as a divide, and it shouldn't be. It shouldn't be us at different extremes, quote unquote. It actually should be a peer CBOs, the clinicians, and the policy wonks at the table. There's no reason that it should be different consultations at different times. That's why I also really, and our organization really gets behind Daniel's Law, because they created a regional council and an accountability council in their legislation to hold the potential response teams that would be peer-led at the state level if this were passed and enacted. They have a council that would oversee that with different people to be able to make those determinations. So I know that's not probably the answer you would like, but I do see—
I wanted the answer you wanted to give.
Yeah.
Can I add to that very
Please,
quickly?
of course.
Just like a beautiful answer. And I think it also adds a layer of, for lack of a better way of articulating it, of checks and balances, right? Because, and I will share this using a personal example, like, I agree. I'm not a clinician. I can't make those calls, make those determinations, but at the same time, as a queer woman of color living with a mental health diagnosis, there is something that I bring to the table and need to bring to the table when in with an advisory psychologist or whatever it is. Because the reality of it, and I chair the Committee on Women and Gender Equity, and so, we've done a hearing on long COVID, and a lot of that focus was on just the historical medical gaslighting of particularly Black women and women of color and queer and gender nonconforming folks, which I've experienced, right? Like, battling chronic pain and autoimmune issues, went to a doctor, a cisgendered white doctor, and when I described my symptoms, what had been going on, was met with like surprise and told, "You're so articulate." I mean, tell that to a brown woman. It's just, what the undercurrents of that are. or just like being dismissed a lot of the time when I'm there to see a specialist in a certain area. You know, I had the struggle of showing up and being like, well, my body is reacting to things differently. I've lost weight and I'm really concerned about it. The first question being, well, were you trying to lose weight? Like, I wouldn't be telling you about it if that was my goal. And this may sound like really not a big, it is a big deal, and it is something that our communities deal with, trying to engage with our medical providers, and especially like when we get to the stage where we have to see multiple specialists and things like that. And so being able to have everybody at the table at once, like, allows for those gaps not to, you know, to remain, and like really closes them, and have tough and hard conversations around how we create the best system that like leaves no one behind.
Thank you, a wonderful point. We're going to pause here and move over to questions from the audience.
What, if any, peer representation do you have on the Coordinated Behavioral Health Task Force, and what are their roles in that forum?
The Coordinated Behavioral Task Force includes the agencies and the outreach partners who are working with this particular population. Many of those agencies and outreach partners themselves have peers on staff. So in that sense, there is peer representation because the folks who are part of that organization are representing all the work their organization is doing, and are kind of there as spokespeople for the various outreach that has been happening during the past week since we last met by their own staff, which includes peers.
At the beginning of this year, OMH issued guidance to inpatient providers that encouraged them to adopt a more flexible approach to involuntary removal. Have you observed any changes in providers' behavior since the guidance was issued? It sounds like a reference to the guidance that was issued by OMH in early 2022 that essentially said the same thing that the mayor's been saying since his speech in November. Right? The mayor's attempt to create a culture shift very much amplified that guidance. So the messaging there is that, in fact, there is a broader sense of what it means to be a danger to oneself than is generally understood, and there is not a need for imminent risk of harm before we can say a person presents a danger to themselves, as long as it appears that they are on a really bad trajectory and we're observing things that make it clear that they're not taking good care of themselves. So I would say that the combination of that guidance with the efforts that we've been making in the city have in combination led to a much broader understanding of it. And look, when the mayor gave his speech, there was a lot of misconstruing of it, a lot of misinterpretation, and a lot of things that came out in the press that were unfortunate and frustrating, that just kind of twisted it and took it in really unfortunate directions. But all that said, I'm actually glad we did it as we did. I think it has started a conversation. It has led to forums like this and others where we've actually had opportunities to really talk to people about what the law allows us to do in terms of helping people, and it has had really good outcomes for many.
Kimberly, did you want to add to that?
Yeah, a couple things. I want to just clarify this notion of culture shift, because culture shift happens when communities are at the table and they're educated before and throughout the process, not at the launch of a policy directive. So we need to really avoid this language, and I really would like for the question to actually be answered, because I feel as though outcomes were not actually presented.
If I could add to that, I will say that, rhetoric matters, because if you are an executive of a city who then is, your agency heads are taking your cue from there, that means something. And so when you take a law and you say, well, we're going to take a broader interpretation of it, and you're hearing from the most powerful executive in the city that the guy shadowboxing on the corner is a danger to himself, that's going to inform the way that the beat cop, the people who, because so many, when you look at the number of city workers we have, the majority of them are police officers. So just by the numbers, the first person who is going to interact with somebody on the street is going to be a police officer. And so we were told that there was going to be a different approach, even if a police officer came, that they were equipped with this great hotline number that they can call to get on the phone with the clinician. Do you know how many times that hotline hotline has been called? Zero. None. Never. A police officer has never consulted that hotline to get best practices from a clinician out in the street when making that first contact. And so, like, those are the pieces of information that matter. It matters a ton. And I also want to say this. The law is not a doctor. And so the law does not always equal best medical practice. And I practiced law for almost a decade before coming into the council, and it was incredible to me that we were tasking and allowing prosecutors and judges to make medical determinations that they had no business making. I would come in with my client and bring their doctor with me and get them on the record and have them make a recommendation, only to have the folks who make and implement and enforce the laws say, we're going to ignore the medical expert on what this person needs, and we're going to punish, or we're going to control, or we're going to dominate, or we're going to take this patriarchal approach that we know better. We know better than this person's doctor, not even a doctor, this person's doctor. And that's a real problem that I think that we have to contend with. The law is not best medical practice, and that is exactly why SEIU, CIR-SEIU, the union of doctors and residents and interns, came out in opposition of this policy as the people who are treating these folks, to say, hey, this isn't best medical practice. So the law and best medical practice, they're not one and the same, and I think that's important to remember, too.
Can I respond to some of that? Thank you. So first of all, I think it's important to actually recognize how the legal process works for any opportunity to civilly commit somebody to a hospital. That is, when a person is admitted to a hospital by a doctor who makes a determination, ultimately that person has an opportunity to challenge that confinement in court. And so, we are in a situation where, yes, a judge is making a determination as to whether the person meets the criteria. But the law is pretty clear that that determination must be based on medical evidence that is expert testimony that is presented in the court. So this is not something that's happening without a medical professional, a doctor, a psychiatrist, who has examined this person, evaluated this person, and is establishing to the judge by clear and convincing evidence that the person meets the criteria. And might the law be better if we had other doctors rather than judges making those decisions? I think that's a debate we could have, but that's the law we have now, and it absolutely is rooted in a medical finding in every case.
To be clear also, I am addressing the criminalization of mental illness, and so again, because there isn't this continuum of care, and because it's most often a police officer that's engaging with the person, they have a couple of options, a hospital or Rikers Island, that those same rules do not apply when you are charged with a criminal offense, and the prosecutor and the judge are making a determination about the disposition of your case.
Right, which is a whole other conversation we could have, council member, and we might even find more common ground on that than we are today. But, I also just want to respond to this, because it's been brought up a couple of times, this idea that the mayor has suggested that the person shadowboxing is dangerous. I think that's an example of how much of our messaging on this has been kind of misconstrued and twisted and taken in different directions. The suggestion was not that that person shadowboxing, keeping to themselves, throwing kind of tight little punches and staying away from other people, is dangerous in the sense of being scary and is at a risk of committing violence or throwing one of those punches at somebody else. What the mayor was trying to convey, and what I think I'm trying to amplify here today, is that that person may be a danger to themselves, right? They're demonstrating psychiatric illness in their behavior. At the same time, if we can look at them and see that they are doing a really poor job of taking care of themselves as a result of that mental illness, that is, we see that they are emaciated, we see that they're filthy, they may smell of urine. Even if that person is not at imminent risk of harm, the point is they are a danger to themselves in that sense. It's not about stigmatizing or trying to have people be more scared of people we encounter in this situation. It's about sympathy, it's about empathy, it's about care, it's about what we'd want if that person shadowboxing was our brother or our dad.
I'm sorry. I want to bring Dr. Riley into the mix because as a patient, I know what constitutes as a risk to myself or other. It's like a tier 1 state where you can be really at harm, suicidal, certain manic episodes. And so for you to sit here and say that the person who's shadowboxing, because of the failure of our city to help them figure out a way for clothing, shelter, food, or whatever got them there, is now you're putting the onus on the individual as if it's their fault, when that's a cry for help, but it's not a cry for involuntary, all right? So if I'm a risk to myself or other, I'm probably cutting myself. I'm probably doing something that is going to determine my therapist, my psychiatrist, then saying, oh, she needs help, right? But me coming in and smelling with some BO, my psychiatrist is not gonna tell me to go to the hospital. And that is the truth. So I want Dr. Riley to actually respond. And in your determination, what would constitute a situation where an individual is really a danger to themselves or other, because I'm just the patient here, right? It would be better to hear from a doctor.
I think the law isn't just danger to self, but it's inability to care for self. That's the law in Massachusetts, and I think that's the law.
So the point that we're, right, I'm sorry,
Sis, here you go.
I apologize. No, I didn't mean to cut you. I thought you were asking me a question is the only reason I grabbed the mic.
No,
Yeah.
I'm glad you did that.
Okay.
She's speaking.
I thought she was asking me a question, so I
No,
thought...
I did ask.
Oh, appreciate that, thank you. So, right, so we do not have a separate standard for inability to care for self, but our courts have said inability to care for self is a form of danger to self. It is encompassed within what it means to be a danger to oneself.
If I may step out of the role of moderator for 1 second to make an adjacent point, this is a great debate to have, but since we have taken, or the state mental health system has taken thousands of psychiatric beds offline over the course of COVID and has not yet brought them back, some of this is an academic discussion. We've got to advocate to get those psychiatric beds put back online. Natalie, next question, please.
Did you want to complete your answer?
Yeah.
Oh, I thought she did.
Yeah.
I'm sorry.
Sorry. Well, I think for the person that's shadowboxing, you have to really put it in context. So it takes caseworkers and psychiatrists out on the street, for months, observing that person, getting to know the person, and then put it in context. Is the person unable to access food, shelter? And a lot of it, I think a lot of people don't really understand this, and Brian mentioned this, is that if someone has schizophrenia or bipolar disorder, the part of the brain that recognizes the illness is not working. And I always have to remind myself of that when I get sort of frustrated by people who, are denying need for treatment. But it's really a neurological thing. So people can't really understand that they have an illness and that medication could help. So again, the person who with rocks in their pocket or shadow boxing, you have to know much more about the person than just the rocks in the pocket. And I don't think anyone would be sectioned involuntarily removed for just having rocks in the pocket or shadow boxing. But it would really be more about how the person is functioning and how the person is sometimes not being able to access food. I knew a woman who was sitting on a bench waiting for Michael Jackson to come get her, and she was in really terrible shape, and we'd beg her to come in and take a shower and get clean clothes and get some food, and she kept insisting, Michael is coming, I have to stay on this bench. And she had, she really had no idea that she had a mental illness. So I think people like her, luckily she eventually got hospitalized when she was outside in extremely cold weather and did really well when she was on medication. That's all.
Thank you.
Yeah,
We have Time for one more, Natalie?
We do, yes. This will be the last one. How can we hold hospitals accountable for actually treating people who need it?
Put beds back online, sorry.
Well, the first thing I would say is to fully fund our hospital system and make sure that we're taking care of our safety net hospitals and that we're getting Gotham clinics in every council district, because I know that that's the plan, but it's currently not there. I grew up in Queens, born and raised in Queens. We have closed 20 hospitals in the past 20 years. The hospital I was born in does not exist anymore. And so, we can't even get to a question of accountability until we're addressing the fact that the infrastructure isn't there.
Yes, I would also like to add that I really hope that our governor, follows through with her recent commitment. She has publicly announced that she will be putting a fine on hospitals who are not bringing back the beds that have been put offline during the state of the emergency, during COVID-19, in order to best utilize those beds for the state of the emergency, because obviously those beds are not always lucrative to hospitals, so they have a lot of incentive to not bring those beds. But I also want to just divert away from the idea that hospitalization is the best response, because it's not the best response for everybody. And we also have to work on the same with hospitals, staffing. I really can't wait, you guys, to tell you guys about our ER survey at NAMI NYC. We're working on it. We are interviewing people or surveying people who are on the peer side, so somebody who has gone to an ER for a psychiatric emergency, and family members or accompanying loved ones, to get different perspectives, because sometimes when we're in certain states, we perceive things differently, right? And so from that, we know that because of the lack of beds, because of the lack of care, some people are staying on gurneys up to 3 days in hallways, sitting on the floor of waiting rooms, waiting to get admitted, right? So when we think that hospitalization is the best first line, I wouldn't say that that's always the case here in New York City.
Please join me in thanking a lively panel. And let me thank all of you for spending part of your day with us. I think the turnout this morning is an indication of how important these issues are to the people who do this work every day in New York City. That's you. And I want to thank you for being here, and thank you for being engaged in the dialogue. And we'll see you at our next policy seminar in the spring.
Thank you all.